Welcome. I'm Shelly O'Neal from the Green Velvet Couch, and I'm a therapist, a wellness coach, and certified corporate wellness specialist. On this podcast, I have the honor of talking to people who will be sharing their inspiring stories about how they've overcome obstacles to really live their life to the fullest. Hopefully, you'll leave the podcast being challenged, informed, and sharing a few laughs as we talk about hard things in a relaxing and fun manner. And as the owner of a 100-plus employee healthcare company, I know firsthand that corporate wellness is personal wellness. I'm super excited to have our renowned local expert, Dr. Laurie Ballew, with us. She is a psychiatrist, and she was the head of U of L psychiatry department. So I'm going to let her share a little bit more about her own background, credentials. I think you have 3 doctorates. And also just share her journey in the mental health field and how she arrived at the place that she is today. So welcome, Dr. Ballew.
Well, thank you. I appreciate that. Uh, I was actually chief of service for psychiatry at U of L Hospital. Dr. Tasman was the chair of the department while I was there, so I wouldn't want to take anything away from him, but I was chief of service there at U of L Hospital. So, reaching to becoming a psychiatrist was kind of a circuitous route for me. I went to Murray State. I was going to be a music major. So that didn't last very long. I love music. I love the piano. I still play the piano. But I decided that I really wasn't good enough to be a classical pianist, and I just didn't really want to teach music. So I then majored in English and psychology because I loved English. I wanted to be able to teach others the beauty of the English language, the linguistics behind the English language as well. And then I met someone who was getting their degree, their master's in speech pathology. And that kind of jived with English because you can't really speak English if you have trouble speaking. So I thought, I want to do that. So I became a speech pathologist. I completed my master's degree at Murray State in speech pathology and worked as a speech pathologist. Then I got a doctorate in program development and a doctorate in speech pathology, and worked as a speech pathologist here in town for 16 years and helped to start the speech therapy program at Mercy Lourdes Hospital and did start the swallowing study program there. And after doing that for 16 years, I saw so many clientele that had brain injuries and strokes. I wanted to be more medically involved. So I wanted to go to medical school, and I did. Initially, I did my internship in family practice and loved that. But I had a connection with patients. And in our internship year, we had our own clinic. And most of my clinic, the patients had mental health issues. And the people would say to me, "Oh, send those patients to Dr. Ballew. She sees all the patients with the mental health issues." And I soon realized that was my niche. And so then I got accepted into the residency program at U of L, and the rest is history. And, I graduated, became board certified in psychiatry. And that's what I've been doing for the past number of years. And that's what I enjoy and love.
It's a great journey. So it kind of evolved.
It did.
So, and as a psychiatrist, and I know you're also an addictionologist as well, and am I correct in a neuropsychiatrist?
Well, we're also trained in neurology. So to be a neuropsychiatrist and to advertise myself as a neuropsychiatrist, I would have to have board certification in that. And I don't, but I do evaluate the patient's neurological issues. And if they need to see a neurologist, I will refer.
Okay. That's awesome. And especially in rural areas, finding, a psychiatrist and one with a lot of experience and training, very, very difficult. So I guess I'm just curious, what are some of the routine mental health issues that people deal with on a daily basis that you see? And like, what does a day in your practice look like?
Well, a day in my practice, at this point in my practice, I see patients who have anxiety, who have depression, who may have some psychosis. psychosis is being out of touch with reality, but the majority of my patients are patients 60 and above. When I was at U of L, I did an extra 6 months in geriatric psychiatry. So at this point in my career, being the person that's has extra attention to the geriatric patients, I see a lot of geriatric patients, patients who have dementia or patients who have a health problem that's causing them to have depression. So I see a lot of comorbid illnesses with the psychiatric issues. So a day would be seeing patients who are mostly some in their 50s. I do see younger patients who had head trauma and such as that. So I tend to focus more on the neurological issues in psychiatric patients as well as the medical issues in psychiatric patients.
I've heard you say this. I've heard you make the statement that mental health is more than a pill. Like, tell me, tell me what that means to you. Because I know a lot of people come in, they want a medication, as a therapist that make their symptoms, their triggers, and their behaviors just magically go away. So our job is really to teach people skills, coping skills, techniques, and to provide interventions so they can navigate their mental health issues. So when you say mental health is more than a pill or you hear that, what does that mean to you?
Well, to me, it means that we need to treat the whole person, and that's what I try to do with my practice through emerald therapy and holistic psychiatry is to treat the whole person. The whole person is who we are when we get up in the morning, who we are when we eat lunch, and who we are when we go to bed at night. So it's our life throughout the day. And think of what your life is, what our lives are throughout the day. It's our nutrition, it's our exercise. It's our interaction with friends and others. And it's our resilience to be able to withstand some of the things that happen during the day if they weren't positive things. So we treat, or I treat, the person that lives their life throughout the day. So holistically, that means nutrition, exercise, getting in touch with nature or your spirituality, whatever that may be, interaction with others, and then, if needed, medication.
And I know you refer to like yoga and Tai Chi
Mhm.
and that sort of thing as well. So, well, let me ask you about the difference between alternative medicine and holistic medicine. Like, help me and our listeners understand the difference because I think it's confusing.
Right. Well, holistic medicine is treating the whole. So, just as I referenced, what a person's life is during the day. So, holistically, we treat the nutrition, what we eat, our exercise, getting a balanced routine in one's life, the spirituality that a person may have, whether it's going to a church, a synagogue, or communing with nature, sitting out in their gazebo, having a glass of tea or a cup of coffee. So, holistic is the mind, body, spirit. Alternative medicine is delving into those things that aren't part of routine allopathic or osteopathic medicine. So, alternative medicine is using herbs, spices, acupuncture, all those different things that aren't necessarily part of allopathic or osteopathic medicine. So, if you go to an acupuncturist, that's alternative medicine. If you go to a masseuse, that's alternative medicine. If you take St. John's wort, that's alternative medicine. So people can go to a health food store and there are all kinds of alternative medicines there that aren't part of the uh, routine medical practice.
It's really helpful to know the difference and kind of to understand that because I think they get intertwined
Mhm.
a lot. Let me ask you about the belief that people can change because you've been a psychiatrist for how many years now?
Uh, 29.
And as a physician, you've done things like you delivered babies
I
at,
did.
at one point. Did you tell me around 100 babies?
I did.
Okay, so you've really seen, and now you're talking about you spend a lot of time with geriatric patients. So the whole lifespan of a
Mhm.
person, you've really been able to be a part of that. So, do you believe that people can change?
Well, yes, I wouldn't be sitting in this chair talking to you right now. People can change and people do change. Changing is just a matter of desire, need, and contemplation and acceptance. So let's say someone smokes and they want to quit smoking. So that desire, that wanting to quit, and that contemplation of quitting is that little flame of wanting to change. So, giving them guidance on how to quit smoking, providing medication if they can't do it without medication, plus the coaching to quit smoking. We would do that. And people quit smoking. People quit smoking every day. So that's a big change because nicotine is a very addictive chemical. So people do change. People change in their interactions with others. You know, when I was a kid growing up, I was very shy. I'm still very shy. I'm an introvert. But when I need to be an extrovert, I can make myself be an extrovert. So that's a change. So people can change out of need and out of desire.
I love that. Out of need, out of desire. And a lot of our focus at New World, and we're so very fortunate that we joined forces with your practice, and now we're one, and we always say that we're stronger together as female entrepreneurs and business owners and professionals. But but with that, I think comes just a lot of responsibility. And with that responsibility of treating people and things, do you find that education is key, like understanding a mental illness? And how would you define a mental? Like, what's the difference between a mental illness and just an annoying behavior?
Well, an annoying behavior is something that just kind of irritates us. But we can continue our lives, our work life, our home life, our social life. A mental illness impairs one's functioning, daily functioning throughout the day. So let's take an example of a child in school who has obsessive compulsive disorder. And let's say that child has obsessive compulsive disorder so severe, and their need to make them feel like they can get through whatever task it is to count to 13. So they count to 13 before they do anything. So what happens? They're not able to get their work done. They're late. They can't pay attention because they're busy counting to 13 to be able to complete the task. So that illness impairs their daily functioning. Where if it was just a little habit of twirling their pencil every once in a while, like we all do, it's a big difference because when we have a mental illness, it impairs our daily function.
With that mental illness comes to diagnosis, and you have to meet criteria. It's a very systematic approach. It's not just, oh, I think you have this or that. So I find, as a therapist, that a lot of people are fearful. They don't understand, like when you say mental illness or mental health, it's a negative connotation. But really, all of us have mental health, just like we have physical health, spiritual health, financial health, and emotional health. So, what sorts of things do you think decrease that stigma of mental health and making what would encourage people to seek services versus being fearful and not wanting to have a diagnosis?
I think one thing is to educate the public that our mental well being adds to our physical well being. When people have a cardiac event, what happens? They have chest pain, they could pass out, have loss of oxygen, maybe they need CPR, they go to the hospital and they get a stent. Uh, and all surrounding that is not only physical health, but mental health. How does that affect the person? Do they become frightened? Are they afraid to go out by themselves since they had that cardiac event? So it's important to explain that mental health and physical health, it's all intertwined. Our brain is controls the rest of us. If I tell my brain to do something, which is my brain really saying it or telling me to do it, then I do it. If I can use Tai Chi to calm down or use mindfulness meditation to calm down, it not only helps my mental well being, it helps my physical well being. So I think it's important to educate people that mental health and physical health are intertwined. That's where the idea of holistic comes in, mind, body, and spirit, because our mind is not, you can't cut your head off and sit it over here and say, well, there's my mental health and here's my physical health walking around without my head. That's not the case. We're all one person. So our mental well being helps control our physical well being. How many times do people say, oh, I'm so stressed? Well, if we don't learn to take care of the stress, then eventually it can become a mental health issue and an anxiety disorder. So if we can learn to deal with some of these daily, I would say, interactions, some of them are aggravations, but if we can learn to deal with those in a positive way and accept the fact that maybe our mental health can help our physical reaction to the stress, then we'll have a better understanding what actually mental health is. People really don't like the term mental illness, but no one seems to mind to tell me they're diabetic or they have fibromyalgia or they have asthma or COPD. All those physical illnesses affect our mental well-being. So people don't like that term mental illness.
Yeah, you're exactly right. That stigma that comes with it. But
Mhm.
you're right that none of us have a problem sharing. We're, have high blood pressure, we're diabetic, or something like that.
Mhm.
Well, one of the things I'm curious about is I know you're also an addictionologist.
Mhm.
So tell me about that and talk a little bit about an addictive personality and just the how you came into treating people that were struggling with addiction and what type of addiction?
Mhm.
Drugs, alcohol, other substances, food, gambling.
Mhm.
Tell me a little bit about that.
Okay. So, when I was at the University of Louisville on faculty there, I had the opportunity to get extra training in addiction medicine. So, I took that opportunity and I took my boards and passed my boards and became board certified in addiction medicine. So, because I have that certification, I treat patients and have others at my office, nurse practitioners and physician assistants, who treat patients who have opiate dependence or addiction and alcohol addiction, methamphetamine addiction, the various addictions that we can treat on an outpatient basis. I have found that being able to treat people who have addiction gives them a new life. Nobody wants to be an addict. Nobody wants to be an alcoholic. Nobody wants to be an opiate addict or a methamphetamine addict. What happens is if a person uses a substance often enough and long enough, the body becomes physiologically addicted. They may initially use that substance to feel better, but then if they use it often enough, they will physiologically become addicted. So there are all kinds of different personalities. But in the DSM-5, which we use for diagnosis of mental illness and mental health issues, there's not an addiction personality in there. That's not a diagnosis. Addiction happens oftentimes because of a genetic predisposition. So if one's mother and father had addiction and they have 4 children, all those 4 children are going to have a propensity to become addicted if they use. If one parent has addiction and they have 4 children, maybe 2 of those children will have a propensity to become addicted if they use. In alcoholism, there's a enzyme in the liver called aldehyde dehydrogenase. People who don't have enough aldehyde dehydrogenase to process alcohol are much more susceptible to becoming addicted to alcohol. Many Native Americans don't have enough aldehyde dehydrogenase in their livers, and so they have a hard time processing alcohol appropriately and may be more prone to become dependent on alcohol. So, just the chronic use of something can make us become addicted.
And I think one of the things I keep going back to is we never know how much years based on our genetics is going to put us in that place of active addiction.
Mhm.
For some people, my experience is they can drink or use something for many, many years and become addicted much later in life. And then I've seen other people who, after what I would consider a very short time frame with use or issues, become addicted, pretty quickly.
Mhm.
So I think that's important to know about about the genetics,
Mhm.
how we're predisposed. So when you're working with the addiction population, what are some things in families that you have noticed? It seems to be how that family operates and how it functions. And I'm thinking more along the lines of maybe some entitlement, enabling. What are some common family interactions that you see that you think that can magnify addiction, make recovery more challenging?
Well, I think the major symptom that I see in families who have a loved one or more than one loved one who has addiction is shame and fear that other people will find out. And so there's the shame that they have this son, daughter, husband, mother who has addiction, and so they keep it quiet. And it's the big white elephant in the room, and they don't want anybody to know about it. So oftentimes they're reluctant to get treatment. So that's one of the major things I see. The other thing I see is enabling, where people have an alcohol, and you see it with any addiction, but tend to especially see it with alcohol addiction and you see it with opiate too, because those are legal, but alcohol is so easy to get that you have a person in the family who is addicted to alcohol, who's an alcoholic, and they're disabled. They can't go and get the alcohol, but a family member will bring the alcohol to them. So you see the enabling of the continuance of the addiction. And part of that is that family dynamic of wanting to help the person, the fear that they would go into withdrawal, and just the whole realm of not wanting people to know that their loved one has this severe situation.
I'm thinking of a story of a client I worked with a few years ago when I really looked at their entire family. And these were good people. They were healthy people. They were involved in their community. They were well educated. On the outside, it looked like they were checking off all the boxes of having a really great life. But they had a lot of addiction issues in their children. One of the things I noticed was it was almost like holding that entire family hostage. Like
Mhm.
parents, like their physical health really went downhill, and they didn't enjoy relationships with their grandchildren. They didn't travel. They stopped going outside of their house a whole lot. In working with them, they finally were able to verbalize that they felt some guilt about going on with their life when their adult child or adult children actually were struggling. So that enabling that I saw, and tell me if you've seen anything similar, was it was this belief that I'm going to wait until this person gets healthy before I go on in my life, before I'm happy, before I'm successful, before I'm at peace. It was when they get a job, they get sober, when they get blank. And it held the whole family hostage. And they were loving parents, great parents, but that enabling looked healthy. It looked like they were just being good parents. But what really was happening was they were sending the message that none of us is going to be okay until this person is sober. And of course, you and I know that's not how recovery works. It's not how people become sober at all.
Mm.
So what are your thoughts about that situation? What could that family have done differently? Or what's a story that you've seen in working with families battling addiction? Because it affects the whole system.
It is. Addiction is well, any mental health issue, and addiction is considered a mental illness. It's in the DSM-5, which gives us the diagnostic criteria for mental illness. Any mental illness, whether it's addiction or bipolar disorder or schizophrenia, families feel shame and they want to protect the one who has that disorder because they feel the shame that my child has this, whether they're an adult child or a small child. parents feel guilt that this child has this, and why does my child have this? So things that I recommend to family, of course, one of the things I always go over with people who have addiction and family members who come see me who have someone has an addiction is we do a genetic tree, and we start with great grandparents and grandparents. And so we do that genetic tree so they can see this isn't something your son or your daughter just decided to go out and do, that there may be some genetic propensity for this to happen.
So puts that on paper. Like, okay.
Yeah,
love
so
that.
so we do that. And then I also go over a picture of the brain with them and show them the areas of the brain that have executive functioning, making good and healthy decisions, and how start using a drug, whether it's meth or opiates or alcohol, at an early age affects that decision making. So that they have that. People need something that's solid that they can look at. So we go over those ramifications and how they affect the person who has the addiction, and then we go over how it affects them. What happens to them when they come home and they find out that, oh, you were sober for 3 months and now you've relapsed again, and how they can deal with that. And I have found that referring family members and even friends to alcoholics, not Alcoholics Anonymous, but Al-Anon, the support group for family members and friends of alcoholics. I refer families to that, whether the addiction is alcohol or meth or opiates, because it helps people. It's a group. Everybody's in the same situation or similar situation. And it helps them to realize what they're doing is not the most helpful for themselves or their family member who has addiction. And I have people that I've referred to Al-Anon who still go, and there's been sobriety for 2 or 3 years, but they still go because of that support that's helped them to deal with their feelings of guilt and see that, it's not something that I can or can't do. Because you can have 4 kids in a family and only one might be an addict.
And I've just seen the blame that parents carry that they did something wrong. They personally messed up or scarred that child. That the reason that they're struggling is some sort of parenting misstep, which is not the case. We both have seen people who have had amazing families and lots of nurturing that still become addicted, and vice versa. People who had none of that and never ever battled addiction. So I think the shame and the blame that whole family can carry is it can be staggering at times. I think when you work with a family, helping that system, that family system, because I like systems theory, everything's a system, helping that family as a system heal and get healthy and recover to break up some of those old negative behaviors that just kind of keep that addiction rolling. So, well, thinking of the brain, one of the things I want to focus on at the end of our time is TMS. So one of the things we talk about in mental health is technology and be a progressive leader in what's new and best treatment for people. So I know you've been involved in TMS since some of those very first studies. So I want you to talk about the early years and what you're doing now and kind of explain TMS to it.
Okay. So transcranial magnetic stimulation, or TMS, was first FDA approved in 2008. And while I was at the University of Louisville, we started using TMS in 2010 in the Depression Center, which was started by Dr. Jesse Wright. And we started using TMS with the NeuroStar system. So I first became acquainted with TMS in 2010. And I was there at U of L for 20 years, and I left in 2014 and came back home to Paducah. And of course, worked at Mercy for 5 years before opening my own practice. And last year in May, I was able to lease a TMS machine. I had wanted to do this because TMS treats depression. Now it also treats OCD and anxious depression. It could treat that before, but it's FDA approved for treating obsessive compulsive disorder and anxious depression, as well as major depression that's severe. The science behind TMS is there is a magnetic coil that is placed on the head, and we map the brain to find the motor innervating area of the brain, which is next to the prefrontal cortex. We put that information into the system, the computer system that is connected to the TMS machine. When we find the right motor response at the right intensity, that's put in the machine, and it is extrapolated to where we need to treat the prefrontal cortex of the brain, where the emotion area of the brain is housed, so to speak. So magnetic pulses are given to the brain in that area from this magnetic coil. The magnetic pulses create electrical energy. The electrical energy causes multiple neurotransmitters to be released, thus helping to alleviate depression. We do it over a period of 30 days, once a day, 5 days a week, unless there's a holiday or the person's ill. And then we do the next 3 weeks, we just kind of decrease the treatments to 3, 2, and 1. We have found in our office that we've had an 85% success rate over the patients that we've treated.
Amazing.
Nationally, the data show that there's an 83% improvement of patients receiving TMS, and they remain on their medication. And there's a 62% improvement where patients don't have to be on any medication. So that's better than any antidepressant. So TMS has proved to be very helpful to our patient population here in Paducah.
I personally have seen very treatment resistant people get better. People that have tried lots of different medications and lots of different therapies. And then I have seen them go through the TMS treatment. It's amazing. You know, that, like you said, the improvement and, you know, when people, and that's what we're really doing is we're helping people get their life back or help them design even a better life. And that's what I love about TMS. So it looks when you go in to see a dentist, it looks kind of like a dental chair to me.
It's a little more comfortable, I
Is it?
think.
Okay. Well,
Yeah.
I like that. And they go into a little room. I know you have like a screen for them to watch, and it's very relaxing. So they sit in this chair. There's a coil placed on their head, and then it sends that electrical impulses to the brain.
It's a magnetic pulse, which
Okay.
creates electrical energy.
Okay. And then that stimulates the parts of the brain to regulate brain chemicals to improve depression.
Right. And now it's also approved for treating obsessive compulsive disorder and anxious depression, FDA approved. So those studies have been in the works the past 6 to 7 years, but you know, it takes a while to get things approved by the FDA. You have to have a number of studies. So
Do you think that eventually TMS will be? I know there's a lot of different companies that make some of the equipment for TMS, but do you think eventually TMS will become a staple in mental health treatment?
I would like to see it be a staple in mental health treatment. There's ongoing studies right now for the use of a rapid TMS, a more rapid pulse, which ours is fairly rapid now, but this was an extra rapid pulse to use in patients who have Parkinson's disease and also to use in patients who are having dementia and memory disorders. So those studies are still ongoing.
Speaking of those type of diseases, I know you're very interested in treatment issues of Alzheimer's and, you know, using case management and lots of different things like that to improve patients' care. So this rapid pulse TMS could really help improve some of the geriatric patients and some of the things that they've really lost a lot of independence in dealing with.
Well, the studies right now are showing that it does help with short-term memory, but it's still in the early stages. So, you know, we don't know.
But that could be
Mhm.
that could be huge.
It's,
I mean,
it sure.
if you think of people,
Anything that will help, anything
yes,
that will help.
yeah, that's huge and very promising. Well, that's all that I have. I think it was kind of like a buffet of mental health today. We just went from topic to topic, but I like that. I like that because we really want to help educate people and motivate and encourage them. But also, I want to end with you just spending a minute or two talking about how we are designed to do hard things as humans. And I know you've seen people go through very difficult, very challenging things, but still come out and have a beautiful life. So tell me about your own suggestions that like for other people, but then things that you do to improve resiliency.
Well, I think resiliency, some of it is nature and some of it is nurture. I firmly believe that, just like I was talking about that genetic tree. But I think things that help me get through the day are just number one, I like what I do. Number two, I like the people around me that support what I do. And number three, I know that I'm going home to my family that cares about me and they want me to have a good day. And my little dogs, which I love more than anything. And my little baby grand piano that sits in the music room that I can sit down and play that. So it's those kinds of things that get me through the day. To me, every day's a good day. Some days are better than others. And I really, really, truly believe that. To me, when I open my eyes, put my feet on the floor, it's a good day.
I think you're so right about that. How very fortunate we are that every day is a good day, no matter what happens. Still a gift.
And I also remember that even if I may be going through something difficult, there's always someone out there who has something much, much worse.
Yeah.
That may be easy to say, but it's really true. If you just look around, there's always somebody who is suffering more. And if we can get out of ourselves and help that other person, it makes us feel better.
Things I always tell people in session is to identify someone that you know, whether it's in your family, at work, or in your community that's healthy. And what does healthy look like and feel like to you, to each person? And one of the things because I had the luxury of working with you for a short time when we were both at Mercy at the psychiatric unit. And then we both had our separate practices. And then now that we're all combined and now we're one, that one of the things I always appreciated about you and I watched was you filled with gratitude. And I think as a healthy person, practicing gratitude is, to me, it's the measurement of your mental health. Like people that are healthy, it does not mean they have less problems. They're just better at navigating those problems. But being filled with gratitude, no matter what's going on. And I think for you, you're always well regulated. You're always calm. You're always very gracious. You have a lot of gratitude. So I think having the ability to work with you to really see that you implement the things that you tell people. One thing to write a prescription, but you really do tell people how to change their life and how to live a healthier life. So I always appreciated the gratitude that you practice. Is there one thing that you would leave us with today in this conversation that would help us to remember something that's just very important in our own mental health?
That's a tall task. Well, I think it's important for each of us to realize that there's a purpose for us. Sometimes we may not know what that purpose is, and maybe our job in life is to continue that life and continue to search and until we find that purpose. And when we do, we will have a good sense of fulfillment.
That's wonderful. I like that. Well, we're going to wrap. So thank you, Dr. Ballew.
Thank you.
And just go live your best life.
Thanks so much for listening to Shelly O'Neal from the Green Velvet Couch. If you're enjoying the show, please rate, subscribe, and review where you listen to your podcast. That helps others find the show and begin their own wellness journey. Thanks again for tuning in. Until next time, go live your best life.